Imagine a critical medical emergency where the most crucial diagnostic clue just disappears precisely when the patient starts feeling better. Or maybe a sudden life-threatening heart condition triggered not by stress but by overwhelming joy. Sounds like something straight out of a medical thriller, right?
Absolutely. But these aren't fiction.
These aren't just dramatic plot devices. They're real, often subtle ECG syndromes that can be incredibly tricky to spot. What if understanding these rare, sometimes hidden electrical patterns could literally be the difference between life and death for someone you care about? Today, we're diving deep into the fascinating and, yes, sometimes pretty frightening world of unusual heart syndromes that leave their unique signatures on an electrocardiogram. Welcome to the Deep Dive, where we take your source material and basically extract the most vital nuggets of knowledge, helping you become truly well-informed without all the information overload. Our mission today is to explore a spectrum of less common, yet profoundly significant electrocardiogram syndromes. These are the kind of medical mysteries that, challenge even seasoned clinicians.
Exactly. We'll be uncovering how these syndromes manifest clinically, what unique patterns they etch onto an ECG, and crucially, why recognizing them quickly is absolutely vital for patient outcomes. It's really about learning to spot the whispers of the heart before they become a scream for help.
Right. And we've got a fantastic review article from the Journal of Personalized Medicine guiding us today, laying out these diagnostic puzzles and thankfully their solutions. Now, before we jump right in, a special thank you to London Heartbeat's Z Academy UK for their invaluable educational support on this deep dive. They offer over 150 popular courses designed to really broaden your knowledge. So if you're as curious as we are about understanding these complex topics in a clear, concise way, you'll definitely want to explore their offerings. Make sure to subscribe to their social media channels. That's Facebook, Instagram, and YouTube for free. Regular updates so you don't miss future amazing discussions like this one. And for those who want to go even deeper, you might consider their higher-level YouTube membership. You get early access to educational videos and even personal chats and guidance sessions. Okay, so we'll walk you through each of these syndromes, from their intriguing discovery to their specific
Takotsubo, or broken heart syndrome. Where did the name come from, and what does it truly signify? It conjures such a strong image.
It absolutely does. The name Takotsubo is Japanese and refers to the distinctive shape the heart's left ventricle takes during the acute phase of the syndrome. It literally resembles a Japanese fisherman's pot used for trapping octopuses. It has a narrow neck and a wide, rounded bottom. It was first described in Japan in 1990. It's also called stress-induced cardiomyopathy, or apical ballooning. But broken heart syndrome is perhaps the most evocative and widely recognized term, really capturing that powerful link to emotional triggers.
So it's not a typical heart attack caused by a blocked artery. That's a really important distinction, especially since the symptoms can be so similar.
That's the absolutely key defining feature, and it's what makes Takotsubo so unique and often a diagnostic challenge. It's a temporary malfunction of the left ventricle, characterized by this specific apical distension where the bottom part of the heart balloons out and becomes immobile, while the base of the heart remains hyperkinetic, meaning it contracts vigorously. Crucially, this dysfunction is not the result of an acute myocardial infarction caused by an obstructive coronary artery blockage, although in a small percentage of cases they can coexist. What's even more fascinating is its reversibility. Cardiac function usually returns to normal in about 12 weeks, and ECG and biomarker levels normalize within 6 to 12 months. This full, often spontaneous recovery is a hallmark that distinguishes it from a typical MI.
If it's not blocked arteries, what causes this broken heart? What's the leading theory behind this phenomenon, especially considering the emotional triggers?
Several theories exist, but they largely converge on the idea of a massive, sudden surge of catecholamines. Your body's fight or flight stress hormones, like adrenaline and noradrenaline. This surge can be from intense emotional or physical stress, or even underlying medical conditions that cause excessive catecholamine release, like a rare tumor called a pheochromocytoma. One prominent hypothesis is that the apex of the heart, the bottom part, has a disproportionately higher number of beta-adrenergic receptors compared to the base. This makes the apex far more sensitive to these stress hormones, causing it to become stunned or dysfunctional, leading to that characteristic ballooning.
Interesting.
Another theory suggests estrogen's role. It's believed to help protect the heart by downregulating these beta-adrenergic receptors, which might explain why postmenopausal women with low estrogen levels are significantly more susceptible to Takotsubo. Their hearts might react more strongly to catecholamine surges.
What triggers it, and what does it feel like for the patient? I've heard stories about both extreme sadness and extreme joy being triggers.
You're absolutely right. While emotional stimuli like heartbreaking news, the death of a loved one, or an economic crisis are classic triggers, it can also paradoxically be triggered by intense positive emotions, like winning a major tournament, a lottery, or receiving surprising good news.
Happy heart syndrome.
Sort of, yeah. Physical stressors are also significant, including acute illnesses like sepsis, medical procedures such as surgery or even cardiac stress testing, or certain chemotherapy treatments. Patients with underlying psychiatric or neurological disorders also tend to have a significantly higher prevalence. As for symptoms, they powerfully mimic an acute coronary syndrome. Dyspnea or shortness of breath, crushing chest pain often occurring at rest and radiating to the jaw, sweating, nausea, dizziness, and if there's an underlying medical condition, its symptoms may also be present.
How does the ECG help diagnose this emotionally charged heart condition, especially if it can mimic a traditional heart attack?
That's the core diagnostic challenge. In the acute phase, patients typically present with ST segment elevation on their ECG, which is the hallmark of a major heart attack. This immediately prompts a cardiac catheterization to differentiate from a true MI. But here's the critical part. In most Takotsubo patients, the angiogram reveals perfectly clear coronary arteries with no evidence of obstruction, though a small percentage might have coexisting conditions. In the following 24 to 48 hours, the ECG evolves. You can see deep T-wave inversion, significant QT interval prolongation, and even pathological Q waves, which can be alarming. Continuous ECG monitoring is vital during this period due to the risk of lethal arrhythmias like torsades de pointes or ventricular fibrillations, specifically because of that prolonged QT interval. The INTERTAC diagnostic criteria are a modern tool used for risk stratification, assigning points for factors like female sex, presence of an emotional or physical stressor, absence of ST segment depression, except in AVR, and a history of psychiatric or neurological disorders, plus QT interval prolongation. A score of 70 or more indicates a high probability of Takotsubo.
And what about other tests beyond the ECG? What else do doctors look for?
Beyond the ECG, cardiac enzymes like troponins will be elevated, but typically to a lesser extent than in a full-blown MI. BNP and NT-proBNP, which are natriuretic peptides indicating heart strain, also increase. Imaging like echocardiography and cardiac MRI are crucial for evaluating ventricular function, confirming the apical ballooning, and ruling out complications. The European Society of Cardiology also has a detailed set of 7 criteria for diagnosis. These include transient kinetic wall alterations beyond a single vessel territory, new reversible ECG changes within 3 months, absence of causative atherosclerotic coronary artery disease, increased natriuretic peptides, small troponin rise, and ventricular systolic function rehabilitation on follow-up imaging. That reversibility is key.
Okay, let's consider Maria, a 68-year-old widow.
Mm.
She suddenly collapses with crushing chest pain and shortness of breath after receiving an eviction notice. Intense stress right there.
Absolutely.
Her ECG shows significant ST segment elevation, and initial troponin levels are slightly elevated. She's rushed to the cath lab, expecting a heart attack from a blocked artery, but the angiogram reveals perfectly clear coronary arteries. No blockages at all. Instead, her left ventricle appears ballooned at the apex, that classic octopus pot shape. This is Takotsubo syndrome, directly triggered by the intense emotional stress.
Textbook case.
Her treatment shifts from traditional MI management to supportive care, and thankfully her heart function recovers over the next few weeks. It just illustrates how profound emotional shocks can manifest as physical cardiac emergencies.
It really does.
What are the common misdiagnoses for Takotsubo, and what are the primary treatment approaches once it's confirmed?
It's very often initially confused with acute coronary syndrome, specifically with Minoka myocardial infarction with non-obstructive coronary arteries or sometimes Kuhne's syndrome due to the acute symptoms. Initial treatment often mirrors ACS management with aspirin, heparin, oxygen, maybe morphine for pain. However, once Takotsubo is confirmed, the treatment shifts. Mild cases are typically managed with ACE inhibitors or ARBs, which may help reverse the dilation, and beta blockers to counteract the catecholamine effects. If heart failure develops, diuretics and nitroglycerin are added. Severe cases with cardiogenic shock require ICU management and sometimes even a left ventricular assist device. Despite the often good recovery, there's a significant risk of complications, including mortality and a recurrence rate of about 22%, so ongoing monitoring is important. Quiet for 2 seconds.
Are truly critical for early detection, appropriate treatment, and ultimately preventing fatal arrhythmias and sudden cardiac death. The potential for misdiagnosis and dangerous treatment delays is very real when these conditions aren't recognized. Each pattern tells a critical story that healthcare professionals must be prepared to read, potentially transforming dire situations and quite literally saving lives.
If you could distill our deep dive into a few top essential takeaways, what would they be?
Okay, first, the ECG is not always straightforward. Crucial diagnostic clues, like in Welland syndrome, can appear when symptoms are absent. That counterintuitive presentation is vital. Second, the heart can react physically to intense emotional or allergic stressors, as we saw in Takotsubo and Kuhne's syndromes, showing a profound mind-body or immune-cardiac connection.
Right.
Third, not all serious heart conditions are caused by blocked arteries. Some are purely electrical or genetic, like Brugada or Lepard, shifting focus from plumbing to wiring. And finally, some athletes face unique cardiac risks, like Papillama syndrome, due to strenuous training, emphasizing that fit doesn't always mean no heart risk. It highlights the importance of personalized approaches.
To leave you with something to ponder, considering the intricate and often subtle signs of these syndromes, what other seemingly normal physiological responses might be masking critical underlying health issues that we are yet to fully understand? Makes you wonder how many more hidden messages our bodies are trying to send us. Quiet for 2 seconds. Multiple choice questions. MCQs. All right, it's time to test your newfound knowledge with some quick questions based on our deep dive. Don't worry, we'll give you the answers and a quick explanation. Ready? Number 1. Which ECG syndrome is characterized by T-wave changes in V2, V3 when the patient is pain-free, indicating a critical LAD artery stenosis? A. De Winter syndrome, B. Takotsubo syndrome, C. Welland syndrome, or D. Brugada syndrome?
The answer is C, Welland syndrome. This one's unique because its classic T-wave changes in V2, V3 appear when the patient feels fine, signaling that intending LAD blockage.
Okay, number 2. In De Winter syndrome, what is a key ECG finding in precordial leads that differentiates it from a typical STEMA? ST segment elevation greater than 2 millimeters, B. Deep Q waves, C. Absence of ST segment elevation with upsloping ST segment depression at J point and peak T waves, or D. Prolonged PR interval?
That would be C. Absence of ST segment elevation with upsloping ST segment depression at J point and peaked T waves. Even though it's a STEMI equivalent, De Winter typically lacks that ST elevation, showing specific depression and peaked T waves instead.
Number 3. Kuhne syndrome is defined with a simultaneous occurrence of acute coronary syndrome, ACS, and what type of reaction? A. A viral infection, B. A systemic allergic reaction, C. A cerebrovascular accident, or D. Renal failure?
The answer is B, a systemic allergic reaction. Kuhne syndrome is that combination of ACS with an allergic or hypersensitivity reaction involving mast cell activation.
Question 4. What emotional or physical trigger is commonly associated with Takotsubo broken heart syndrome? A. Extreme physical exertion only, B. Chronic inflammation, C. Heartbreaking events or intense stress, emotional or physical, or D. High cholesterol diet?
It's C, heartbreaking events or intense stress, emotional or physical. Takotsubo is strongly linked to sudden, severe emotional or physical stressors causing that catecholamine surge.
Number 5. Yamaguchi syndrome is a specific type of hypertrophic cardiomyopathy, primarily affecting which part of the heart, often resulting in a distinctive ace of spades appearance on imaging? A. The right ventricle, B. The left ventricular apex, C. The left atrium, or D. The interventricular septum?
The distinctive shape points to B, the left ventricular apex. Yamaguchi syndrome specifically involves hypertrophy of the LV apex.
Okay, number 6. Which of the following is a classic ECG triad for Wolff-Parkinson-White WPW syndrome? Short PR interval, normal QRS, absent delta wave, B. Long PR interval, wide QRS, inverted T wave, C. Short PR interval, wide QRS, presence of a delta wave, or D. Normal PR interval, wide QRS, ST segment elevation?
The classic triad is C. Short PR interval, wide QRS, presence of a delta wave. This shows the accessory pathway bypassing the AV node.
Number 7. Lone-Gannon-Levine LGL syndrome is distinguished from WPW syndrome by the absence of what ECG feature, despite having a short PR interval, A. Q waves, B. T wave inversions, C. Delta wave, or D. ST segment depression?
The key differentiator is C, delta wave. LGL has a short PR but a normal QRS, and crucially, no delta wave.
Question 8. The diagnostic type 1 ECG pattern for Brugada syndrome involves what specific finding in the right precordial leads, V1, V3? A. ST segment depression greater than 1 millimeter, B. Coved ST segment elevations greater than 2 millimeter, followed by an inverted T wave, C. Prolonged QT interval, or D. Flat T waves?
The diagnostic pattern is B, coved ST segment elevations greater than 2 millimeters, followed by an inverted T wave. That specific cove-type elevation is the hallmark for type 1 Brugada.
Number 9. Friedreich syndrome is the simultaneous occurrence of atrial fibrillation or atrial flutter and what other major cardiac event? A. Myocardial infarction, B. Complete heart block, C. Ventricular tachycardia, or D. Supraventricular tachycardia?
Friedreich's is the combination of AFib or flutter with B, complete heart block, third-degree AV block.
And finally, number 10. Papillama syndrome, affecting young and middle-aged athletes, is characterized by recurrent episodes of what arrhythmia, often linked to strenuous long-term training. A. Ventricular fibrillation, B. Atrial flutter, C. Paroxysmal atrial fibrillation, or D. Sinus tachycardia.
That athlete-specific syndrome is characterized by C. Paroxysmal atrial fibrillation linked to that long-term training and cardiac remodeling. Outro.
And that wraps up another truly illuminating deep dive. We hope you've gained a clearer understanding of these fascinating and sometimes hidden heart conditions that remind us how incredibly complex and resilient the human body truly is.
Understanding this broad spectrum of ECG syndromes is really a testament to the power of medical observation and the ongoing quest for precise diagnosis. Each unique pattern tells a critical story that healthcare professionals must be prepared to read to help ensure the best possible patient outcomes.
We're always learning, and we love sharing that journey with you. Until our next deep dive, stay curious, stay informed, and keep exploring.